Hey guys, so today we are going to be discussing triceps pushdowns and assisted dips for our exercise comparison project.
So the triceps brachii has three heads, a long head, a lateral head, and a medial head. All three of these extend the arm at the elbow, and the long head also extends and abducts the shoulder at the glenohumeral joint. All three heads insert on the elbow at the olecranon process, and the two exercises that we're comparing using the triceps are assisted triceps dips and cable triceps pushdowns. So in the top right picture, you can see the assisted triceps dips. The subject has their knees bent on a cushion with their arms fully extended, with their hands right by their side, grasping the handles, and they begin the exercise by flexing their elbow to lower their body until their elbows are at a 90-degree angle, and then they return to the starting position by pushing through the hands. In the bottom right picture is the cable triceps pushdown. The subject is standing with their arms at 90 degrees and their feet shoulder width apart, and they need to be sure to not change their distance from the cable column or the lever arm will change. They hold the rope with a narrow grip, and it is overhand grip as well with their elbows by their side. They begin the exercise with elbows at 90 degrees and pull the rope down until the elbow is fully extended, and then they return to the starting position with arms parallel to the floor.
So here's a qualitative description of the triceps pushdown. Um, if you're looking at frames 1 through 3, we see an extension motion occurring at the elbow. This is the pushdown motion of the exercise, which is being caused by the concentric contraction of the triceps brachii. And frames 3 through 5 is the flexion motion occurring at the elbow where the pulley is being released, and this is the eccentric contraction of the triceps. And here's the free body diagram of the triceps pushdown. As you can see, in red is the force of the pulley, and in orange is the force demand of the triceps muscles, and in purple is the joint reaction force. Here's a qualitative description of the assisted dips. In frames 1 through 3 is the descending motion. Motion is occurring at two joints here, one at the shoulder and the other at the elbow. Gravity is causing the shoulder to extend, which is requiring eccentric contraction of the shoulder flexors, such as the biceps, coracobrachialis, and anterior delt. This motion is also causing flexion at the elbow, which requires the eccentric contraction of the triceps. And frames 3 through 5 is the ascending motion of the exercise, which involves the concentric contraction of the shoulder flexors and the triceps. And here are the two free body diagrams for the assisted dips. Two because we have two joints that we're looking at. On the left is, you can see the contact force in green is causing a flexion moment at the elbow, and on the right you can see that the contact force is causing an extension moment at the shoulder.
So like Barrett just mentioned, the prime movers for our tricep pushdown is going to be the triceps muscles. And then some secondary muscles that help assist that motion are the pec major, deltoids, rhomboids, and the latissimus dorsi. And then for the dips, our prime movers are the triceps brachii, along with our biceps and our anterior deltoid. And then the secondary movers are our pec major, deltoids, latissimus dorsi, and also levator scapula, because sometimes you have individuals compensate with bringing their head forward. And then stabilization occurs at the trunk, and that is done by the back and the abdominal muscles. So the major joints moved, like mentioned, for the push down, it's going to be the elbow joint, and we're going to have them go from 90-degree flexion at the elbow to a neutral position, so elbow extension, and we're going to avoid hyperextension. And then for the dips, the two joints that are moving is the glenohumeral joint. So that one is going to be neutral in the beginning, and as we go down, it's going to go into 45 degrees of extension. And then for the elbow joint and the dips, it's also going to be neutral in the beginning, and then it's going to go into about 90 to 100 degrees of elbow flexion. So in the down phase, the elbow should be perpendicular to the floor and the shoulder should be parallel with the ground. So in the dips, the greatest stress is seen on the glenohumeral joint at the anterior deltoid muscle. And this is because we tend to put a lot of body weight on our shoulders as we press up and down. And if we don't have proper form, then we're likely to put a lot more risk of like injury and impingement syndrome at our shoulder. And then for the push down, the greatest risk is at the long head of the triceps. And that is because the shoulder is stabilized. So the long head plays a significant role in the extension motion. And to go off of that, a study found that placing electrodes on the muscle bellies of the triceps and having the participants perform tricep pushdowns, they saw a lot more muscle activity from the long head of the triceps compared to the other heads. Next.
Alrighty, so for some biomechanical differences, we'll begin with the triceps pushdowns. So the greatest demand comes from the resistance in the middle of the movement. So during this exercise, the force is bringing the shoulder into flexion. And so because the triceps long head extends the elbow as well as extends the shoulder, it is very active because it is extending the elbow during the exercise, but also resisting shoulder flexion simultaneously. So for triceps dips, the highest demand is when the elbow is most flexed, and this is due to the lever arm being the longest. So the force is going through the shoulder, and so the lever arm is through the elbow, resulting in the creation of elbow flexion, which leads to activation of triceps. So if the hand placement during this exercise is not correct, for example, if the arms our hands are further back, so away from the body, the force is going through the elbows, and then the arm pushes the body into extension. So this would lead to a strengthening of shoulder flexors and not shoulder extensors, which in our case is the triceps. So some common mistakes. So for both of these exercises, people may have poor technique and poor body mechanics. So hyperextended back, which leads to increased arch, as well as like elevated shoulders and flash motions. This just leads to like inadequate activation of the muscles, which isn't really getting what we want from the exercises. So in particular to the assisted tricep dips, would be again incorrect hand placement, and we don't want the shoulder to extend as well as the elbow because this could lead to active insufficiency of the triceps. This can also be caused by increased chest length. So for the triceps pushdowns, on the other hand, some of the things, some common mistakes would be locked knees. Again, that would be due to poor technique. And positioning of the elbows outwardly as well as wide grip on the handles kind of go hand in hand. This causes the elbows to go outward, so not as close to the body, which would lead to the activation of other muscles and not quite isolating the triceps in actual extension. So you want more uniformity during the exercise. I want like more external demand to match the internal capacity. Alrighty, so for the assisted dips, there was some pain and discomfort felt in the chest and front aspect of the shoulders when performing this exercise. And there was some soreness felt several days after as well in these areas. And this may have been due to us not having our hands in the correct position. So we were, or maybe also some chest lean. Triceps pushdowns, on the other hand, none of us felt any pain or discomfort during the exercise, but some felt some slightness in our triceps a couple days after. So collectively, we all agreed that the triceps pushdowns were more enjoyable because we felt like they were easier to accomplish. Um, this exercise did not require as much stabilization in the core in comparison to the dips, which put less strain on our bodies and required less energy for us to complete for the 15 reps.
So this is the gait analysis portion of our presentation. Our subject was a 7-year-old male with cerebral palsy. And here on the left is the video in the frontal view. And we'll be looking at the left leg as the reference limb throughout this presentation. And we notice significant gait deviations in both the beginning and end of the gait cycle. So just keep an eye on the ankle, knee, and hip at those points in time. All right. Starting off with initial contact and loading response, we can see that the subject had an inconsistent contact pattern. Specifically, the subject showed forefoot and flat foot contact. And also, if you look at the image on the right, you can see a limited plantar flexion at loading response, as well as excessive knee flexion. If you look on the image on the left, you can see some genu valgus or excessive knee abduction, as well as you can see internal rotation of the pelvis and ipsilateral pelvis drop and excessive femoral anteversion if you look at that toe-in gait on the image to the left. You can also see an ipsilateral trunk lean looking at the image on the left.
So in terminal stance, this patient lacks full knee extension, and this can be seen on the image on the right. He also has some genu valgus, which can be seen on the image on the left, again in reference to his left foot. So the patient also lacks hip extension on his left side and has posterior rotation to compensate for that. On the image on the left, you can see some pelvic drop as well as some excess internal rotation leading to excess toe and ankle.
So the last deviations that we saw were in the terminal swing phase, and we can see that the subject has limited knee extension. You can see that on the picture on the right, and that could impair his ability to shock absorb and weight accept as we go into the initial contact phase. He still has the genu valgus. Also, you could see that in the left picture, and he has excessive internal rotation of the ipsilateral pelvis. And you can see that as he's moving forward, his left limb shifts a lot more forward than the right. And that could be causing his increased toe in gait. And again, this could cause problems with like foot clearance. But in his case, he's able to avoid that. And like mentioned before, since he does have cerebral palsy, that could be due to the spasticity of his internal rotator muscles. And Kirby's going to talk a little bit more on that now.
So potential causes for these deviations are cerebral palsy, as we mentioned before. Present with this is typically high tone and increased spasticity of the muscles, specifically in the lower limb. Toe walking is also typically present due to the increased tone, and patients typically have weak abductors, which causes that pelvic drop, as well as tight adductors and hamstrings, which contributes to the excessive knee flexion. They also typically have weak antagonistic muscles, such as the abductors and knee extensors, which is observed in his gait pattern, and typically excessive plantar flexion is present as well. This patient has had some past treatments, such as bracing at the ankles to increase dorsiflexion, taping to increase dorsiflexion, as well as recently had Botox injections in his left leg to decrease the muscle tone and spasticity and improve overall gait mechanics of the entire lower extremity. So these are the references that we used, and we'll be taking any questions now if y'all have any.